Hi, it's Dr. Sonia and Dr. Krissa. Today we want to discuss constipation and fecal loading and bowel flushes. For many of you, you're very familiar with our recommendations, and hopefully you have seen some of the successful results of really flushing the gut safely but aggressively. So Krissa is going to go into some of the research on this, and this is to help give you more information, more knowledge, and to keep you motivated to get that biofilm out of the gut and make sure the gut has the opportunity to heal.
Great. So I think with the constipation piece, I do remember when Sonia and I learned constipation over 20 years ago, the term constipation was very large. Like if you had a bowel movement once every 2 weeks, you were constipated. But keep in mind, this is the large intestine. So a lot of our fecal loading cases will happen in the rectum and the sigmoid colon because it is lacking the gravity piece. When you stand up, stool will go down here. But this is the holding area that's very common in our patients. So when we're looking at what is normal, we often talk about the Bristol stool chart, which is kind of in the corner here. Let me move us real quick. So the Bristol stool chart, when I took Sonia's maternity leave, everyone was talking about type 1, type 2. I'm like, what are they talking about? But she had trained her patients on the Bristol stool chart. So keep in mind, a normal bowel movement is a type 4 from your fingers to your elbow or your wrist to elbow. The which should be your OK, the symbol of your OK thumb. Anything that's larger is constipation. And anything that is not optimum is more likely to be inefficient or constipation. So I think the optimum type of bowel movements we're looking at mean that the function of the digestive system is one thing, but if you have something stuck in the pipes, you can have regular bowel movements around this debris that's stuck. So we have very medical definitions of constipation, which we learned in this little fat book in our offices. But the definition of constipation was rejigged a little bit as of 2019. And the rejigged or the more optimum definition for constipation talks about how a huge percentage of kids would have it. I mean, up to sort of 20 to 30% of those kids going to see a doctor would have functional constipation. So the definition would be things like infrequent stools, less than 3 bowel movements per week, abdominal pain when you're having a bowel movement, incontinence or having stool come out that it shouldn't, or stool with maneuvers, which is when the children usually are making positions. That's actually a clinical sign of constipation. Sonia talks a lot about the kids that lean on their parents or lean on beds or lean on chairs. What's that one called again?
Yeah, so that term is called posturing,
Posturing.
and they'll push their belly into furniture. Or I had a little guy not too long ago, he was leaning over the desk coloring, and there was a lot of pressure on his belly. Some kids lay on the ground. Recently, I had a child who was hugging his mother, but he was hugging her sideways, so her hip was sort of driving into his intestine. And then, of course, you'll get kids who just push their own intestines. But I ask a lot about this, and a lot of the parents are not recognizing that this is a quite significant sign of fecal loading. So much so that the physicians, that's one of their flags to requisition a bowel x-ray to identify the fecal loading.
And keep remembering things like blood in the stool, but also getting up at night to pee lots or wetting the bed. So, wetting the bed is actually almost a very classic sign for constipation that's brand new, that we've sort of been learning about for a long time, Sonia and I, but now it's actually in the medical constipation assessment. So, also remember the toilet training experience your kids went through, or really skinny kids or kids with some weight. That can also be clinical signs of constipation. This is when the kids have fecal loading and it's actually poking into their bladder, and that's when they pee the bed at night. Not because they have any issues with the bladder, actually, it's because the bladder wall relaxes, and at night, then they sort of relax that tone and then they pee. So, Sonia talks a lot about the medical aspects of constipation, and this is the paper, the Tim Bui paper. She talks about with all of the major symptoms that would correlate to constipation or fecal loading.
Yeah, this one, I look at this paper almost every day. I send it to almost every family, and we go through it together, or I have them print out the symptoms their child is experiencing and highlight, or print out the paper and highlight the symptoms their child is experiencing. And just kudos to this group of doctors and researchers, because these symptoms 90% of the time correlate with something going on in the bowel. And in my experience, that is almost always fecal loading. So from tapping to constantly wanting to eat to the posturing Krista talked about, waking up in the middle of the night, crying for no reason, being angry, irritable, frustrated. And the wonderful thing about this list is that it is almost always completely treatable if we can flush the old stuff out of the bowel.
Can you do that that cry that you picked up, that like the type of cry that you can hear in the office, and you know for sure it's fecal loading?
Yeah, I mean, I'd say I leave 100% to a higher power, but 90+% of the time, if I hear verbal stimming, that's like, and keep in mind it's going to be louder than what I'm going to do here, but it's like this kind of sound, that is almost always something stuck in the gut. It is very medical. It's very treatable. We need to understand that before we say something's behavior, children need to be properly evaluated. And that's what this research article is saying, that we need to evaluate the gut when children present with these behaviors. And it's life-changing, right? Because the behaviors are medical, and when they're medical, they're treatable and reversible. And then if children are not so preoccupied with feeling uncomfortable and pain, they can do other things. They can make more eye contact. They can play differently with toys. Hopefully that opens up, and it often does, opportunities for communication, social interaction, and learning.
And you can't always see it on palpation. So when doctors try to palpate masses in the stool, you can't always feel it and you can't always see it. So when we're looking at diagnosing, so these are just some things that are secondary constipation, which we'll just leave in for your information. And then the definition of functional constipation legally or technically, we'll just kind of leave that in there. But when we're talking about the assessment piece or the diagnosing piece, physical exams shouldn't be excluded, obviously, but really like the bigger cases should actually be worked up with a bowel x-ray assessed for fecal loading, and ultrasounds don't work for this type of diagnosis.
No, I've had kids get ultrasounds and the ultrasound says it's fine, and then they get a bowel x-ray and it's severe fecal loading.
Mm-hmm. So
and the doctors, sometimes they can't palpate children diagnosed with autism, and even if they do, they can't, because of the way that the intestine is tilted, right? Our organs aren't just flush, they tilt, and that part of the bowel, particularly the right side, the ascending colon, it's hard to figure out if there's stuff stuck in there.
So what we ask patients to do is ask the doctors for a bowel x-ray assessed for fecal loading. It's called a plain abdominal x-ray or a KUB x-ray. And then the x-ray technicians will do the proper assessments, and the diagnosis on the findings area should be normal. And if it's mild, moderate, or severe, it's bad. It's medical. Stool should not show up on an x-ray. That's better for bone, highly calcified or dense tissue. When you're seeing stool show up on a bowel x-ray, it's old. It's really old. It's calcified, like turned into stone old. So then it has to be medically treated, and water and diet and fiber are not the way you treat it. That's the way you maintain it. You can also do a transit time test where you eat something and you check how long it takes for you to see the food for the last time, not the first time. So you can eat something colored like beets or purple dragon fruit, and the transit time should be sort of 8 to 18 hours or 24 hours, and never see that food again. So you try 2 different foods if you can, with 2 different fiber contents. Corn, everyone can see corn in the stool, unfortunately. But your transit time with a colored food and corn should both be, I see it the next day and I never see it again. Pass. If you're seeing it 5 days later, 3 days later, fail. There is fecal content in there that shouldn't be there.
And it stops the absorption of nutrients. When we look at autism and other developmental concerns, there's such staggering nutrient deficiencies. It's because the stool is literally blocking the absorption of nutrients. And I think we're going to touch on the nature of the stool, right? And being sticky, gooey because of the microbes, but I'll let you keep going here.
Well, I think that's the 2-piece process is 1, take it out, and 2, then maintain the treatment, because the stool itself can be sticky and hard, but once it's on the inside of the digestive system on the bowel, it can also, you can lose some of your tone when it's been there for a while. So you want to keep everything moving and not allow the stool to stick back there and lose that elasticity. If you've blown your tone entirely, you can see it on a bowel x-ray, but you can lose your tone a little bit and it looks okay on paper. So you sort of want to pull all the junk out and then maintain the tone for a period of a long time, so the adult, the child, can have time to pull that elasticity of the pipes or the digestive system back to where it should be, which can take minimum 6 months to a year. So,
well, in autism, the kids already have issues with tone. They have mitochondrial impairment, they have impaired motility, so they're going to get a lot of damage to the intestines and to, a lot of problems with getting that tone to return to normal, which is why replenishing with all the fats is so important, because the fats give your muscles tone, whether it's the muscles to communicate, to make eye contact, or for the digestive system to function properly.
So we can't really move on to maintenance therapy unless we are out of disimpaction therapy. And I think what we're finding is it takes a long time to get everything out. And so we think it's like a one and done, or I've done it for a week, or I've done it for a month. And our job is to make sure we see that the disimpaction is done and then move you to the maintenance therapy. But almost always we're sliding back to there's still debris in the pipes, and it can be sticky and hard to get out. And our cases where we're seeing chronic infection, that stool is like phyllo pastry, like glue, cement, glue, cement, glue, cement. And you can't peel cement off your desk with a sponge. You really got to pick it off, and it takes time and effort. And soap and water aren't going to do it. So the right tools have to be used for the disimpaction protocol. And then sometimes a slightly different plan is going to be for maintenance therapy.
Yeah, disimpaction for my folks is the bowel flush, pediatric bowel flushes.
So this is why we decided to call the digestive system pipes, because it's very visual, and you are talking about trying to get the debris off, but that debris can be sticky, and until you get it clear, then that's when you move on to that maintenance therapy. So we use magnesium oxide in our clinic almost exclusively now because of the benefit that we can see, and the dose can be a lot smaller than you can do with other substances. So magnesium oxide is going to be different than, say, Restorelax or Peg Flakes, because the type of osmotic or water diarrhea that it induces is slightly deeper and more aggressive. And these agents we're used are generally called osmotic diarrhea agents, or water through the pipes. So we don't want to use something that makes the bowel lazy. We don't want to use something that's going to scratch the inside of the pipes, and we want to do something that can be used long term, because it can take a while to get the stuff out and maintain the flow. So you can give the bowel time to pull, well, to heal it, to give more tone, that's Sonia's saying, but also make sure the tone is going in the right direction. So I guess in Asia, magnesium oxide is still used, especially in Japan, but in the world, magnesium oxide was used preferentially. I mean, it started with magnesium sulfate as a constipation protocol in like the 1600s. But now what we see is some places have stuck to the magnesium oxide as a therapeutic mechanism, because it's got a curative model. Like you can get out of this situation if you pull the debris out of the pipes. And I think some of the problems we've had over the years is that we thought we'd moved on to the maintenance therapy, but we weren't out of the disimpaction, spot yet. And so this is probably the most aggressive but safest tool we found to do that. And one of the reasons is because I'll give you this little visual here. Oh, I'm going to move our faces a little bit. So why magnesium oxide is because it does blend with the hydrochloric acid and the gastric acid. It then converts into magnesium chloride, and then it will actually use a bit of the base, the pancreatic juices, to make a bit of a base. So it's got an acid and a base kind of hustle to it. And the type of osmotic diarrhea it will shift is will also generate some gases to pull the debris off the pipes. So it's not just going to push water through the pipes, but it's also going to have a safe, very gaseous type of combination that will move things through the pipes in a lot more stable way. And then the magnesium is safely eliminated in the kidneys. So we know this magnesium oxide can be done at high doses, and it can be done safely. So that's kind of why we've used it. And places in Japan have used doses like for adults 2 grams 3 times a day for years to get the disimpaction and the maintenance therapy in play.
Yeah, which is 2,000 milligrams, right?
Right. Yeah. So yeah, these are kind of like a sample of one of our standard constipation protocols for kids, as we start low and then we go higher and higher and higher, and we're looking at making sure you see the stool come out of the digestive system. So Sonia does this really well, but she also winds up seeing in her cases that parents can do lots and lots of magnesium and there's no fecal matter that comes out. There's just like brown water or water and very little fecal matter. So then there has to be higher and higher doses of magnesium, so you're actually getting the debris out. If you're getting hard stool and you're putting water in it, you're making kind of muddy stuff, sticky stuff out of it. It's going to go down a couple feet, but you have to get a dose that's consistent enough to really get that debris out of the pipes.
Yeah, and this handout is the softening. So this is what you would do daily in the morning and before bed to keep softening the stool, but not turn it to diarrhea. And then when you do the pediatric bowel flush or the bowel flush for adults, then it's much more likely to come out. So the daily magnesium The goal is to soften but not create diarrhea, and then do that daily until it's a high dose magnesium day. Ideally, you're doing magnesium oxide, and then you're turning the actual stool as much as you can to water. And then with the gas, the gas that gets produced with the chemistry Krista just went through and the flushing, then you can see all kinds of stuff come out. Like I could for hours sit here and tell you things that parents have reported, from mucus to old snail, sticky, gooey stuff, hard, dry balls, stuff that sticks to the toilet, stuff that looks more like bark than stool, just straight up mucus. Really unbelievable what's stuck in there. But at the same time, if you compare it to the severity of the symptoms that our patients are experiencing, it does make sense that the gut is this compromised and this filled with old garbage. And that's what I say. I mean, if you're going to renovate your home, you can't have it filled with garbage. So when we renovate the health of the body, the cells, the gut, the brain, we need to have enough of this garbage removed so we can make a big impact. And that's why this treatment is so important, and it's very safe. It's very successful.
This is our sample of our clear out protocol, and we fill it in based on a child or an adult or the weight or the severity of the bowel x-ray, and sometimes also the patients, right? Like what their symptoms are. So yeah, this is the more aggressive clear out that we do expect lots of diarrhea. Yep, I mean, like when lots of people ask about the why, and I think generally our food has been compromised. That's why we always suggest change in diet, so we have stronger nutrients, food that has more fiber, but also less processed food. And because microbes are always in the digestive system, we choose food that is not going to grow them and allow them to control the environment where that sticky glue-like scenario just keeps on being produced. So we choose food that's highly dense in lots of nutrients, but is not going to grow any microbes.
Yeah, and the biofilm, as I always talk to my families about, if you have heavy metals and you have opportunistic microbes, or even more pathogenic microbes, they're going to live together in a biofilm. So whether they're yeast, bacteria, parasites, viruses, they all live in the biofilm, which is basically like a house made of metals and minerals covered by cotton candy, which is the gooey, sticky stuff. And that will stick to the gut wall until you flush it. And when you flush it, it does. It's like tar, sticky, old stuff. And so people will ask, well, how do we treat microbes? You starve them and you flush them. How do you treat metals? You flush them. And so out with the mucus is the biofilm. It's a very, very effective way to detoxify the body and to get rid of microbes. And then the last thing I say to all my families is that if you have yeast or Clostridia or strep or Lyme or co-infections, if you feed those bugs, they will stay. If you starve them, they'll go. So, the diet has to be in place. Not saying it's easy, but certainly having these symptoms that we see in autism, all these behavior, aggression, self-injury, tics, tapping, constantly jumping and running, waking up in the middle of the night, that's not easy either. So that's why these bowel flushes are super important, as Krista calls it, de-impaction. And then to maintain it, we need to make sure the diet is in place so the kids don't keep reaccumulating all that stuff and all that junk in the gut.
I think this slide talks about fiber, but you can't put fiber on a bad diet and expect to have change. You have to change the diet so it changes the digestive system, the environment to the digestive system. So we tend to recommend no carbohydrates, no dairy, and no white potatoes. And it's hard, but it's very treatable and it's very successful. So thinking about the dietary recommendations on top of a highly processed diet won't work. And you'll get these numbers. You'll get these fiber numbers, no problem, when you change the diet. So you don't have to even track the fiber. All right. I think
that's it.
I think that, let me just see real quick. Yep. I think that's probably it for our constipation presentation. Yeah.
Yeah, I think we flush it and then we work on healing. And I think we should get on in another video and talk about all the different healing strategies that we have. Okay.
Great.